Welcome to The Bridge, a podcast on how leaders use data to make decisions in the military community. I'm Shannon Razsadin, the CEO of MFAN and also a military spouse. The Bridge is your go-to source for informed conversations about the programs, policies, and lived experiences that shape military family life. We're highlighting the voices and the stories that are making a difference, and we're grounded in data and driven by purpose. The Bridge podcast is produced by Rocket Data. Thank you all for being here, and let's jump right into the next episode. Welcome to this episode of The Bridge. I'm thrilled to have everybody here with us today. We're going to have a really interesting conversation around health and what that means for rural communities. Healthcare has been a really hot button issue lately. It's something that has been a hot button issue for, frankly, years. And we're in a really unique time right now, and I'm thrilled to have two experts join me here today for this episode to really dive into what they're seeing, the role of technology, and some opportunities that could lie ahead as it relates to rural health and what we really all need to be aware of. So, Dr. Mike, it's wonderful to have you here. Travis Dalton, wonderful for you to be here this morning with us.
Thank you.
I'll let you both introduce yourself and just share a little bit about who you are, your background, and frankly, why this conversation is important to you. And we can start with you, Dr. Mike.
Dr. Mike Place. I'm a Army family physician, now retired. My career spanned both operational and clinical assignments and ended up as the chief of staff for Army medicine.
And you're also on the MFAN board of directors.
I am. It is a privilege to serve there with great people like Shannon.
I love it. I love it. And Travis, go ahead.
Yeah, thanks, Shannon. Dr. Place, good to see you, sir. Yeah, so I'm the CEO of Claritev now. We focus on affordability, transparency, and we provide networks across the country. Prior to that, I was the president of Cerner, heavily involved in healthcare for 20 years, very involved with the DoD and the VA. I'm also on the board of the Elizabeth Dole Foundation, have been for quite some time, focused on caregiver issues. I'm very proud of the work that group's done. 23 years in healthcare, and then this year, we launched in partnership with the National Rural Health Association. I'll just do 2 seconds on why this matters to me. So I grew up in a small town, like many, across the street from rural Ohio. Across the street was a 200-acre cornfield. And so my mother actually worked in the community hospital where I grew up. My mom she worked in admitting, she worked in the ER, she worked in billing, she probably swept the floor, she may have worked in the cafeteria, I don't know. But it was very, very, very much a central part of our community. I tell people all the time, the waiting room of that hospital kind of raised me because my mom would take me and I'd sit out there. I knew everybody in the communities. It was beyond just the care you get. It was an anchor in our community. And so, keeping that resilience and keeping those kind of places in business and vibrant is just super important to me. It really goes all the way back to my childhood in a lot of ways.
I love that. In a previous life, I did some work for the Census Bureau. And we were out in rural communities in Georgia and having conversations around why the census was so important, everything from hospital beds to, what the funding looks like. And it's critical. And I think that people don't necessarily think about the potential gaps or the existing gaps and what that looks like and the differences and disparities that can exist between urban and rural. And so I'd love to start the conversation there and hear from both of you about what the current landscape looks like as it relates to rural healthcare and where you're seeing gaps. And are those gaps persisting or are there new and emerging gaps that you're seeing? And Dr. Mike, we'll start with you.
So historically, rural communities, because of a combination of provider, doctor, nurse, technician shortages, as well as, quite honestly, financials that don't support being able to see small populations, it becomes difficult to maintain practices across rural America and, quite frankly, even in urban locations sometimes. Get underrepresented. I grew up in rural South Dakota, so everybody there rub some mud in it and you're good, right? That's just how they kind of grew up. And so there's a persistence of this lack of capability across much of rural America, and quite frankly, even in some of our cities and small towns. So there are some emerging gaps because of things like telehealth and so forth, that rural America doesn't have the bandwidth literally to be able to do that. And it becomes cost prohibitive. There's going to be access challenges. There's going to be capability challenges for specialties and specialists that are going to persist outside of our major urban centers.
Yeah, that's a great point. What about you, Travis? What are your thoughts here?
I've had the interesting experience of working with providers, working inside the military health system, working with a lot of payers. And it's interesting, there's always this implied, like sometimes there's an implied ill will amongst the two sides. I actually see both sides
Yeah.
want to solve the problem. But we're in a very kind of a misaligned incentive environment. And what I've seen a lot, what I think we've seen some of is just this idea that you can solve, scale is the way to solve these problems for large health systems. So you see a lot of acquisitions, you see consolidation, you try, expense and cost cuts, you see scale advantage, try to be the thing. And sometimes that impacts, rural facilities. They're not able to remain open, not able to remain viable. They're not able to remain properly funded. And all of that leads to a lot of the things that were just discussed, travel issues with having to travel from Delaware, Ohio to Columbus, Ohio. That was cost for my family that we couldn't incur. And sometimes we didn't have a car that worked, things like that. And so there are very practical things that hit you in those rural communities that happen when those shortages in access present themselves.
Yeah, I think Elizabeth Dole Foundation has done a great job of illuminating. You mentioned transportation, and the miles traveled and what that cost looks like for your family, not to mention time away from work, childcare, all those other things.
It's a complex ecosystem.
Mhm.
And in many ways, we as a nation have tried to simplify this in order to make solution. And at least in my estimation, we'll talk probably solutions later. Anything that we're looking for a solution is almost certainly going to fail. It's got to be an adaptive system. It's got to be able to grow as new technologies emerge and new processes emerge. So to me, that's been the challenge, is that a single solution is laid on the table, and that is just not going to work because of all of the dynamic changes when you're talking about people's health. And there's a lot of emotion that goes with that. And then ultimately the policy changes that have to continue to happen in our political environment. It's very difficult to do that. So that's how we end up finding ourselves here, at least in my estimation.
Yeah, here. There is no one size fits all solution for this or really anything. And that's something that we see time and time again in the data, both from the perspective of rank or age, but also geographic location. And one thing that we've seen consistently through the research is the impact that access to healthcare has on family stability and readiness. And I'm going to use a New England word, but I'm wicked excited to be able to take our data to the next level in the future, to really look at and overlay things like rural zip codes and what that means and what that looks like from the perspective of access to healthcare. So can you talk a little bit about how you see that play out in the readiness and family stability situation?
Healthcare, like many of these kinds of issues, is incredibly personal and it affects people deeply. So a new onset diabetic teenager, I mean, that fundamentally changes that family and what they do, how they do it, what they eat, where they go. All of those things matter. And so we view it a lot as, well, it's healthcare with a big hand. But the reality is it's so individualized that if you can't get access because of time, distance, or specialty, or whatever, you end up not having healthcare. So what that means for military families is if that impacts you and you can't get access, then you need to reevaluate from a family perspective what's important to you. And most of them understandably say, hey, I'm going to take care of my family first. A job, an occupation, oftentimes a calling, but at the end of the day, you have other responsibilities that are going to impact. In my experience working in the Pentagon, healthcare has always been a top 2 or 3, oftentimes number 1 issue for families, for military families. It's always a challenge, whether on active duty, reserve, or guard, doesn't make any difference, that your situation becomes problematic. And it does impact families. They make decisions based on their ability to get quality health care as they define it for whatever their individual family needs are.
It's so true. You both know my family's personal story with this. My son had his traumatic brain injury, life stops, right? And we made family decisions around, military wanted us to go to either Italy or Hawaii, which on paper sounds amazing, or just from an idea perspective sounds amazing, but we have access to some of the best doctors in the world in being in proximity to Boston, and the stability and the continuity of that care when he was in a state of fragility was so important to us. And so, Travis, how have you seen this play out? Because you have a unique vantage point, really seeing a lot of different sides of how healthcare and healthcare delivery plays out.
It's this idea. I was with a CEO of a rural hospital recently, and he said, Travis, I don't want to be the perfect thing for everybody. I want to be the perfect thing for my community.
Yes.
Can you help me figure out what that thing is? And the answer is yes, because we can actually look at it in better data, better insights, better fit. And when I say fit, you can look at clinical and claims data publicly available, evaluate those things together, and you can actually predict what's going to be needed in a particular community. So do we need a bariatric center? I don't know. Let's look at the claims data. Do we need a women's health center? I don't know. Probably. Let's look at the data. What other investments do we make? And so it's actually making smart choices that maximize the ability to serve the community, but also maximize the expense profile. That's running a business. You have to run the business. Infinite things to do, finite resources. And you could start to customize networks as well in rural communities. And so to me, I'm getting into some solves, but we know the problems. The problems are all the things that Dr. Place mentioned: delayed care, lack of education, family troubles, surprise bills, financial impacts, stress. You add all that up. But I do think that we're starting to enter a point in time where if we get together collectively and think about this holistically, as noted before, we've got some tools in our toolkit. And I know we're going to talk a little bit more about those, but um, I'm optimistic that we can start to work on these things in a meeting. I think the time, I'll just make one more editorial comment.
Yeah.
I think the time might be now to work together.
I agree.
I really do. I mean, I think you're seeing the environment change with payers and providers. You're seeing a willingness to come together and share information. You're seeing prior authorization work, a lot of things that need to be worked on to drive inefficiency out, drive care opportunities up, and make it just more simple to access care and the systems that are there. So those are some of the things that we're seeing and thinking about.
And resources are finite, right? And so as all these opportunities continue to emerge, MFAN's team has been growing. And one of the things that we consistently challenge people to do is just because we've done something a certain way doesn't mean you shouldn't say stop, is this really the right way to do this? Mm-hmm. And that's a really important conversation. Dr. Mike, how have you seen this play out in MTF's military treatment facilities, and just really in how military medicine is delivered and thought about for the now moment, but also futuristically?
Yeah, so I've been part of several different analyses thinking about how to optimize the system given the resource constraints. And it has to do with matching a combination of services, whatever, bariatric services or gastroenterology in general or whatever, and matching those to population bases and figuring out costs of transporting people there as opposed to having them have the service at their location. Okay, which one are we going to do? MD Anderson down in Houston, I mean, they take cancer patients all over the country. Well, we could do the same thing in the DoD. We haven't, but those sorts of efforts can be, from a business perspective, a more efficient and effective way to deliver the care. Obviously, there's drawbacks in terms of you're not with your family or your local community and so forth, but those kinds of analysis are ongoing. They make a difference. They really do. The challenge is that the DoD doesn't exist to optimize the business of healthcare. It's really to project power on behalf of the nation. So it's not only figuring out the business of healthcare piece, but it's the DoD mission on top of that complicates that and drives it to be far less efficient than it could be as a business. When people look at it, they tend to look at it only one lens at a time. And so, the DOD and, guys like me would get called over to testify or whatever to say, well, how come you're not efficient? Well, we have this mission thing that we have to do, and there are decisions being made reference to that. And then you get called from the mission side and say, well, how come you're not, forward based and have all your resources there ready to, well, there's this business thing that, the folks that actually pay the bills say that that's kind of important for us too. And so balancing both of those is the very difficult task.
Yeah. And there's a really interesting friction, I think, between the private sector and in some cases the MTFs and what, Defense Health Agency is putting out. And one of the things that we've seen as a real pain point is like the shifting, right? Okay, you're going out to the community to get your care. Now, actually, we're going to start bringing you back into the military treatment facilities. And that creates some real instability. Travis, can you talk a little bit about how that plays out in rural communities in particular? There's the patient side and what that leads to as far as instability, but what does that do to the providers when there's kind of that, okay, just kidding, we're going to change paths here? How does that play out and how does that impact providers and healthcare in general?
Inside the DoD and inside the VA at the deepest levels and at the highest levels on the ground and at the secretary level. I mean, and I just remember those early discussions, many of them around this idea of creating a enlistment or cradle to grave for a beneficiary record through interoperability, through common systems, through the ability to share data and information. And just how complex it was because of the mission, right? Because we do have a mission, defense mission in this country. And, there were things like, I just remember the dental integration. I was thinking here, one of the major reasons that, folks are declared unfit for duty is because dental records weren't integrated into the medical record. The dental record integration, those are solvable problems. Forward deployments, thinking about how do you put a medical record on a laptop or on a device that's mobile? Does the medical record become skin and marker when you're in a battlefield situation, or the memory of someone, or who knows, right? And so there are unique, challenging situations that are real that I think require that specific mission in a lot of ways. You think about DoD, they see many ways people at their healthiest, young, enlisted, healthy. The VA sees many people kind of at their unhealthiest in certain situations, or they take care of things that may not be cared for in some cases, like burn units and certain other things that are really, really important for this country and for those that have served. And so I think, I still am a firm believer that the foundation's been laid, the technology's been laid, allow us to create more holistic solutions to look at some of those things, but also predict what may come or what may not come. To the provider question, look, I think it's, I don't know. I mean, most of the providers I know went into medicine for, one reason it's because they care about people. They like to solve problems. They probably were good at math and science, which I was not. And they had the mission to serve, and they end up, being pseudo data entry specialists. And so, as you're seeing a multitude of patients, as things come in and out, as the system is fragmented, it doesn't just impact the patient, it does impact the provider in a very real way. It detracts from what you want to do with your life, the purpose that you felt. It frays at the edge. I think I'm not one, but having just met thousands of them around the world, you start to question your motivation when you're not doing the thing that you're purpose driven to do, which is care. And so I think it's incumbent upon technologists to put the right data at the right time, in the right place, in front of those making those critical decisions, not to replace cognitive process of somebody that studied 20, 30, 40, 50 years, but to give them information to make the best decision.
I'm really excited to see what the data are going to show and really how we can take that information and go into conversations with patients. And this is going a little bit off script, but so I live in Rhode Island and we have a real challenge here as it relates to healthcare providers who accept TRICARE. And it's become a huge problem. But Travis, what you were saying, I had a conversation with one of my doctors and she said, I'm taking TRICARE because I feel it's my patriotic duty. However, we are losing money. Dr. Mike, from your vantage point, like there's some ethics, I think, involved here, right? As far as that what people should do, what people should have access to. What are some of those things that you think DHA may be wrestling with as it relates to that and that access for people.
The last iteration I went through on active duty with this, one of the comments was just that we were initiating the transition to try to bring particularly more retirees, those with more expensive healthcare, back into the system. Provided complexity, additional medical challenges for our active duty population for the medical treatment facilities. So lots of good reasons to want to do that. Unfortunately, you can't take all of them. Looking at consolidating to have more capability and more capacity at nodes. And with that, at some of the smaller places, we were going to take military uniform personnel and put them to medical centers and so forth. So you could see these other patients that are more costly to the system, all that kind of thing. Well, when you look at it on the flip side, then in small town America, now you're taking the uniform providers there, and there aren't a lot of civilian providers there. So you can rapidly overwhelm them with additional patients, many of which may be healthy, but they still have ongoing medical requirements. And some of them are going to get sick with various things. If there's already insufficient capacity in small town America outside your favorite military base, well, having an additional 10,000 people now needing healthcare, they probably don't have the capacity for that. In fact, we had to ultimately not take uniform personnel from some of those locations simply because there wasn't capacity, and it was likely going to take years for that capacity to be built. Obstetrical care was probably the one that was the leading because it's relatively urgent, and when it happens, you only have a matter of months. So if there's not sufficient capacity there already, which in a lot of those places, if there wasn't, you're going to have to leave some family physicians and OBs around to be able to deliver babies, because if not, they're going to have to travel hundreds of miles or, just deliver at home. Some people like that. That should not be the policy to force people to do that. So, because that's effectively what we would have done. So you scale back some of your desires to be able to meet truly the requirements for access to care with those business decisions. That's always the difficult conundrum working within this. Again, in the complex ecosystem that we're talking about, it is not just uniform folks. It's not just DoD employed folks. You have to take into account all of healthcare across the country for all of your policy decisions. Otherwise, while you might want to do something, you practically can't, just because it's going to adversely impact so many people. It's just a non-starter. So it becomes a wish rather than a policy. Probably the classic is our Air Force bases tend to be relatively small in terms of the number of people. Important mission, critical mission, but they have medical requirements, and because there's pilots and maintainers and so forth, you have to have them. They have to be there. Okay, well, there's a lot of little hospitals. Little hospitals tend not to be very efficient. Okay, so let's go ahead and close some of those. Okay, so now they're going to get care on the economy. And then you start looking in these smaller towns, there's a lot of little ones. So Mountain Home, Idaho, there's a little tiny Air Force base in eastern Wyoming. And many of them just have these little hospitals. And you just go, well, yeah, we should just close those. From a business perspective, it's an easy decision. Just close it. We don't need to make an outpatient clinic. We'll be fine. Well, yeah, except there's no place for those people to get care. So now you have a very different problem set that you can't solve because you can't direct a community to hire a bunch of doctors and build a hospital, all that sort of thing, particularly if 2 years from now or 3 years from now or the next administration, we reverse that policy.
Can I make a comment on that?
Yeah,
it's probably related to the question set. It's interesting. Like we end up, there's a lot of discussion around reimbursement. It's like, and I get it. I understand why, but I do think that there comes a time where we shift that to efficiency. And I say that because, I actually think that markets can work when you have good information, when both sides have good information. And so I think that there's so much, waste and inefficiency and lack of data transparency inside of our health system today, that if we work on these problems with data and technology and we come up with real solutions, the discussion starts to change a little bit because you're able to run so efficiently that there's not so much pressure purely just on reimbursement rates. And so you're able to take a more vast array of patients, plans, of insurance, and dare I say, just care for a needy who can't afford anything. Maybe that plays in, right? And so you just look at revenue cycle management, you look at the number of coders there are out there that are just coding and then cleaning up bad coding, and then cleaning up denials, and then recoding it and resubmit. I mean, there's those are solvable technical problems. I mean, we have a rural hospital specifically that I work with where we just said, you know what, we'll just work with. I don't need money. If I do something good, give me money someday. And so just give me your charge master. So we go through the charge master and we look at it. And with publicly available data, because the MRF files are out there, they have to produce both payers and providers. You can go in and you can look at every single DRG that they have, look at their charge master, and you can evaluate that against every other like-sized hospital across the United States. And you can say, hey, for these particular services, you're underpriced, you're overpriced, you're inefficient in the following way. You can then look at that and go, hey, we can also evaluate that against the network rate on offer from every major payer out there. Here's how you stack up.
Yeah.
You might want to consider discussion with your payer. You might want to consider going to the major employers or providers in this area and creating your own network or plan. Their options are there because the information's there. And oh, by the way, I've gone to all the major payers that I know and asked them, are you okay with us providing that kind of transparency data to providers? And they all said, absolutely.
Yeah, that's great.
Because what happens is they get in a negotiation, the payers got information, these rural providers have none. I mean, my mom, she worked in the cafeteria, she worked in the admitting, she worked in the ER, she swept the floor. She didn't have time to go understand that. And so and then you get in the negotiation, and ultimately the provider's like, well, just give us your data and show us. But we don't believe your data. So there's room for an honest broker. And the honest brokers, we've taken the publicly available data. Here's where it stacks up against the network rates on offer, against other pricing that's being provided in the market at a competitive nature. And here's what we think the optimal place is for pricing and service.
Yeah.
They told me, Travis, we have one person who looks at denials on their laptop, and she's a respiratory therapist, and she does it once in a while on the weekends because she had some experience with how this works. That's what we have.
Yep.
And I'm like, well, we could do better than that.
Mm-hmm.
So you can actually evaluate and look at what's going to be denied, why it's going to be denied, the nature in which it's going to be denied, and you can get it right and fix it the first time. I want to be an honest broker in healthcare that literally takes public data and provides reasonable insights so people can make informed decisions.
Mm-hmm.
That's not to say everything's myopic and you're going to have some disagreement, I think, but that's okay when you have the same amount information.
Yeah.
Right?
And
So I think there's a huge opportunity for us here right now collectively. And I think both sides can agree on that. And we start to focus on mutual interest, not positions. And so that is a dream of mine, is to move things from positional discussions to mutual interest discussions. And I think you do that just with clear data that is trusted. And we're at a point where we can bring that to the table, not just us, but many others. So it's an okay time to start thinking we might actually do something to bend this cost curve at some point.
I love that.
It's a dream.
And no,
I think we can do it.
And it's not an, unreachable, unattainable dream. Like, I think we can get there. Travis, can you talk a little bit about, because that's a really great example of potential solutions, right? What are some of the barriers right now that stand in the way? And, one of the things I'd like to ask you both to kind of round us out at the end is, what's your blue sky, right? Like, what, from a policy perspective, from an implementation, like where, we're in, like my husband likes to call it, like we're in a revolution right now. Like we're seriously in a really unique point in time as it relates to capabilities. And so, like, what would that blue sky look like? But let's start with the barriers, Travis, that you're seeing in the current moment that could be standing in the way of some of the things you just mentioned.
I think there's continued fragmentation of care. I think there's continued gaps. And there's honestly a lot of noise. Like I go to these big conferences, and I'm like, man, how would anybody know what to do? I mean, there's 10, 20, 30,000 people there. Half of them are vendors like us. Everyone has the same 3 words on their slide: transparency, AI. It's like I would have no idea what to do. So I think the technology players that can bring holistic solutions, more than one thing, know who they are, and can solve multiple problems are helpful versus a billion point solutions that create chaos and confusion for someone who is just really trying to deliver care in their community, not understand and study the vast ecosystem of technology marketplace. And so I think that it's the monstrous amount of information, data, the confusion, the amount of private equity, other money that's going into narrow niches. Some of that continues to create, I think, continued confusion in the marketplace or around how to create a simple, holistic solution. Because there are real ones out there. We just
Yeah.
have to come together in a thoughtful, simple way to make our value prop known. And I think as a business person and technology person in this space, I owe that. Like, I'm not doing my job very well if it's not understood the value it can bring. It's not a simple, clean example of how it can work so someone can use it and believe in it.
Especially because people are coming to these conversations with different expertise, different backgrounds, different fluency. And so, no, I think cutting through the noise and being able to tell the story of, what the future can be with the right, people, players, solutions together, that makes a lot of sense. Dr. Mike, let's talk your blue sky and if, there are policy related things in particular that you think could be part of that.
Again, it's a complex ecosystem from my perspective. So I don't think a single solution, although I agree with Travis, simplifying it is helpful, particularly on the technology side. We have a combination of a shortage of doctors and nurses and family physicians. So it informs my perspective, but relative to the rest of the advanced economic countries, we have a lower rate of primary care in this country compared to all of them. So we need to have more primary care folks. We need to have more nurses in particular. There are disincentives to increasing the amount of residency programs to produce more doctors and more nurses, because that at least ostensibly could drive down salaries. And for many of them, those are not highly lucrative to begin with. So it becomes a challenge to convince folks that that is part of the solution. I think broadband technology or high-speed internet for rural America, it's coming, but the current sales of politics are working against that. So, but I think it's coming. It's going to happen. I also think we're going to have to, at some point, review things like critical access hospitals. When you talk about data, definition of terms becomes critical. And so I think right now it's 25 miles is the distance between quote unquote hospitals as defined by the US government. 25 miles in South Dakota or Ohio, that's 25, maybe 30 minutes. In some places like Appalachia, that's 2.5 hours, particularly in the winter. So it matters. So we may have to right size some of those. I think there are some other insurance reforms that we can utilize to improve support, particularly to the underserved areas. I've seen proposals for essentially National Public Health Service for some of our doctors and nurses to say, look, you're going to spend a couple of years going to an underserved area, and since there's lots of them, you pick it, and we'll do just like we do a match for doctors to get into residency programs. Well, we can do a match for where you're going to do your service time and your specialty across the country, because there's enough locations that need some of those. And quite frankly, again, I'm from small town America. There's a number of folks that just fall in love with living in small town America because it is a good place. So I think there's some options out there that are going to make this all possible to do. The biggest challenge, quite frankly, in my mind, is building the consensus to make those reality. I don't think they necessarily just happen. We have to have the dialogue at the appropriate level nationally. I think there's lots of potential, and the biggest thing for me that means that we can be successful is I am convinced there's more than enough money in the system. We have to change the system to use the dollars to deliver the care, as opposed to creating more bureaucracy along the way that isn't value added. If it's value added, I'm in, but the non-value added steps, not so much.
Yeah, having the right conversations, I think, is a really important piece of this. That was a great point. That's a great point. Travis, what about you? What's your blue sky?
Yeah, I won't name the general, but I had a friend who was the chief of staff for a well-known leader in the Department of Defense, and he used to say, you knew you were going to have a good meeting if you came in and just drew an anaconda on the board, because the mantra was surround the problem from all angles. So there, you don't just do one thing to solve a problem. You do multiple things to solve a problem, the whole problem. I think that's important when we think about the problem of healthcare, and it's been mentioned multiple times here. It's not just one thing; it's many things. Yeah. My blue sky, I suppose, is, that that we, as a country globally, that we think about. I'm thinking about the comment that was made around recruitment and talent.
Hmm.
That we look at the practice of medicine as a noble profession it is, and it's as esteemed as it ever was or has been or will be. Meaning, it's an aspiration to serve in that way. I think that that's important. I think we should talk about our providers and clinicians in that manner. I think the EMR and predictive analytics, the promise of that needs to come true. So we've digitized the record. Now the promise of that needs to come true. We need to use that data and information to make better clinical decisions, but also more efficiency in the system, which we've talked about. I think we're in agreement that if we eliminate a lot of the cognitive burden that's on those in the system at all, the back office, at the bedside, in the cafeteria, there's so much room for improvement in terms of eliminating inefficiency and cognitive burden. I think that ultimately then goes back to, why many are in that realm to begin with, which is to serve. So I've got more time to serve. I've got better information. So you just naturally, the market starts to work better. And so that service mentality then extends to, hey, now that we have better time, better information, we're right fit for our community. Let's create respite programs in the community. Let's create other programming that maybe goes beyond policies, goes beyond that allows us to do that because we're freer to do it, because we have tightly run, efficient organizations and systems that allow us to use that excess capacity to serve those. What makes the country great is we care about the least amongst us.
Yes.
And I don't mean the least that are like, they're not lesser than, they just need help. I needed help along the way. Lots of people did. And there were people that had no reason to help me that did, for lots of all along the way. And so, caring for those that need some care is a noble thing to do, whether it's free. I don't care if it's free or if it's covered or not. Like we have a responsibility to do that. And so I think policy does matter. But I think if we can just get really good at this thing, that the heart and mind and soul of those that serve will serve. And that's my blue sky, and we'll see, but we'll never stop trying.
I love that.
Dr. Mike and I won't, that's for sure. And I know
I'm with you. I'm with you.
So,
No,
yep.
I think,
as a physician, I will tell you, doctors and nurses will always come through.
Always.
It's what they do.
Yeah.
I think that wrapped it up beautifully. I mean, it's the human piece, it's the technology and data piece, and it's the partnership piece, and having these things work together in a way that creates that anaconda that gets around this big, hairy problem in a meaningful way. As we get new data and as we, eat this elephant one bite at a time, I think that there are going to be real opportunities to continue the conversation and bring other people into it too, because it is necessary. And Travis, you hit the nail on the head. Like, this is what makes a country really special, right? Being able to care for every single person. So
I think so.
Thank you both for being here.
Thanks for having us. Really, this has been fun.
I love it.
Thanks
I
so
love
much.
it. Thank you both. Take care. Thank you so much for tuning into this episode of The Bridge. I want to say thank you again to our partners, the producers of this episode at Rocket Data. And if you want to learn more, we encourage you to subscribe and visit mfan.org to connect with us and listen to our previous episodes. I hope you have a great day.